Medmont in practice today. So we're going to cover everything from analysis, disease detection, dry eye, and then lens construction for your specialty contact lens patients. So the Medmont Topographer is one of those tools that makes it very helpful to us in our specialty contact lens practice. Let's try to discuss everything that we can do with it to optimize how we deal with these more challenging eyes. If we were to start with a pair of topographies, let's start with an actual case, and we take a keratoconic patient with binocular keratoconus OU. We might say, all right, how do we start with this topography? What should we be looking for? Well, let's pick one of the eyes, and one of the first things you might ask is, how do we know it's keratoconus? Now, obviously, from the topography itself, it's clearly a cone, but is there something mathematical in the software that would suggest to us that we're dealing with a borderline case when it's not completely obvious in the upper topography here? If you look down at the attributes, you see your disease detection indices all lit up in red. So your IS, your SAI, and your SRI values are all coming up with red boxes, indicating that this is an irregular shape eye. If they were coming up yellow, that would be cause for concern to look deeper. If it's green, then that's suggesting that it's an absolutely normal eye. So our disease detection indices are telling us that yes, in fact, we do have a keratoconic or irregular cornea. Now we could look at the axial topography, and axial is the best way to appreciate power. How much power is distributed across the cornea, and specifically, how much is within the pupil that might affect the quality of vision? Do we have a regular corneal astigmat? Do we have an irregular corneal astigmat? That's how the axial map can help us. Clearly, if we cut the pupil in half and we say, is this hemisphere a mirror of this hemisphere, it certainly wouldn't suggest that we have a symmetric eye. Another way we could go is to actually click on the areas of the pupil that we're particularly interested in, such as the red, and it comes up 61 diopters. If we go to the bluest color, or the coldest color within the pupil, we're getting 38 diopters. So there's a 23 diopter differential in power from the top of the pupil to the bottom of the pupil. The axial map would suggest to us that this patient is very likely to need rigid contact lenses to provide decent quality of acuity. If we switch over to the tangential map, tangential is the best way to appreciate shape. What's the size of the cone? What's the position of the cone? That's how we might use the tangential. In this case, we could measure across the size of the cone to determine how severe is this cone. Is it a small central cone? Is it a more typical oval cone in that 3 millimeter range? Is it considered a globic cone? Is it the 5 millimeters or greater that we typically see when the condition has extended that far? Now, another map that we use with great frequency is the elevation display. And the elevation map does what the axial and tangential do not. It tells us where the eye is high and where the eye is low. So you might click your cursor up here in the reddest area, and we see there's an elevation of 310 microns. There's a depression of minus 290 microns. So this eye has a change in elevation of 600 microns. Studies suggest that when we have greater than 350 microns of elevation swing, that's where a corneal GP is going to struggle to work. In other words, when you're over 350 microns, that's where the asymmetry of the eye is so high that a corneal GP may not be able to manage it. In other words, we may want to go to a scleral lens. Now, another thing we can do with the software is to drop a theoretical lens on the elevation of the eye and determine if we can create an acceptable fit. And this might be one of the most important things that a Medmont does for us in specialty contact lens practice. It helps us to determine what lens may be called for, and just as valuably, which lens isn't, which lens has a very poor chance of success. So we'll talk more about the GP software as we move forward. Now you can also drop a scleral lens on the eye to determine if you have the right sagittal depth, the right trial lens parameters, if you need to alter the limbal clearance zone, or anything about the fit. So the Medmont contact lens software allows us to place almost any specialty contact lens on the surface of the topography and determine what is the best final path for this particular patient. Now, another thing that a placido-based topographer or reflection-based topographer like the Medmont is, it can provide some tear film analysis or dry eye analysis. So rather than understanding eye shape in terms of power or curvature, you might look at how the elevation swings from one point of data to the next. In other words, where you see all dark blue, that's where the differences from point to point along each one of these rings is so low that it would suggest that the tear film is very smooth and even. Where you see warmer colors, that's where there's a greater differential in height between each one of the measured points. So in this area, the points are showing greater variation in their elevation. In other words, the tear film is most likely breaking up in that area. Now the Medmont's an auto capture system, so if we select that we want to capture a standard topography, all we need to do is center the green crosshair to the apex ring. That's the first step. Then the red line tells you how close or far away you are from the eye. While the red line's landing right on top of the green crosshair, we're right where we want to be. And that automatically captures images. You see 76% up to 98%. Then we're going to click zoom. We're going to make sure those central rings look parallel and even. Remember that a topographer determines the eye from the center to the periphery. So if the center is poorly understood, if there's lots of tear film breakup, lots of distortion of the rings, that's going to create topographical error. That's going to create construction error in how we determine eye shape, eye elevation, and so on. So make sure you get a 95% or better and then zoom in to ensure those central 10 to 15 rings look ideal. Now the Medmont gives you a very large area of capture. As a small cone topographer, it's able to stretch the rings right to the peripheral cornea, which is valuable because if we're fitting irregular eyes, we're generally using larger diameters. So we want to be able to understand clearly the shape where the lens might land. So the typical single capture should give us greater than 10 millimeters of data. So the Medmont gives us one of the largest capture areas. However, you notice there's some cornea missing out here, some visible iris, where we have not been able to image. And that's typical of corneal topography. We don't go limbus to limbus. We typically measure with large cone topographers 8, 9, maybe even 10 millimeters. With small cone topographers, we typically image 9, 10, or 11 millimeters. But if the visible iris is 12, there's a good chance we're going to be missing some of it. So Medmont has this unique feature called the composite eye capture. And what that allows you to do is take photos in different positions of gaze. So here we have a central image, the patient looking right down the axis of the instrument at the center ring. Now we have the patient look 4 rings temporal, and that pushes the placido to the nasal side. Then we have the patient count 1, 2, 3, 4 rings over to the nasal side. That pushes the rings to the temporal side. Then having the patient look up 4 rings pushes the placido reflection down, and conversely having the patient look down pushes the placido to the top. So now you have a topography on every quadrant of the eye, and they can be merged together to create a larger view of the cornea. So the Medmont provides one of the largest capture areas possible on the cornea, and that's because it can use that composite eye feature to merge multiple images together. Now, when you consider you might be fitting this patient with an 11 millimeter contact lens with a scleral lens, it's very important to have this peripheral corneal information. So this Medmont composite eye feature is maybe one of the more valuable functions that this instrument has, and that may be why it's regarded as the specialty contact lens tool, because it's able to stretch its capture well out to the periphery and give us a better understanding of how to start with our irregular lens fits. You know, of course, today we're using more 10, 11 millimeter contact lenses, more larger diameter multifocals. Ortho-K lenses, typically a small lens is 10.5, so more typically we're using 11 millimeters. For our specialty custom soft lenses, understanding the peripheral cornea helps us to estimate the height of the anterior chamber. And that's true of scleral lenses as well, and more so than anything else. We want that peripheral corneal information to build our scleral lenses. So there's another type of capture that we can do. We talked about the single map capture, one single image. We talked about the composite capture, merging multiple images together. You can also do a video capture. What that allows you to do is appreciate the tear film, something that you could show the patient wherever those rings appear distorted or where they're broken. That's where you have dryness or tear film breakup. So it's a very obvious way that you can describe for patients or show patients the type of condition that they have and how dry the surface of their eye is. Remember that a reflection-based topographer reflects off the tear film. It doesn't measure the cornea, it measures the fluid on the cornea. And that's why we can appreciate the dry eye, because we're reflecting off that tear film. It's also an important consideration when we're attempting to get a good understanding of eye shape. We need smooth fluid across the surface of the eye to get a good quality understanding or image of the underlying cornea. Now, if you're doing dry eye assessment, maybe the best function is to use the TFSQ capture, or tear film surface quality assessment. And what that does is it determines the tear film breakup time, the relative surface smoothness of the tear film, and the percentage of area in breakup. So what you do is have the patient blink twice, and that starts the test. Have them hold their eye open as long as they can, and the typical test duration is 15 seconds. If we were to start that video again, we can see that the user is centering the unit, ask the patient to blink twice, and then hold their eye open and continue to center the unit as best you can until you reach a third blink or the 15-second duration. So the test will automatically stop when there's a third blink or when you've reached your target period of capture time. So the TFSQ analysis, tear film surface quality analysis, what it does is it gives you a tear film breakup time, in this case measured as 5.2 seconds. And this may be the best analysis we can do in dry eye with the Medmont topographer. There are other metrics that you can use. The average TFSQ is determining the average of all the tests throughout this entire period. Where was the relative tear film surface quality? And over the course of these 15 seconds of tests, the instrument is suggesting that we have a 0.1 value of TFSQ. Higher numbers mean drier eye. Then you could look at the average TFSQ area, 6.6% of the cornea. It's a relatively smaller area of the cornea that's in breakup, but still significant enough to be deemed within the realm of dry eye. So this patient may have subjective response to dry eye testing or dry eye surveys. Now, we use the tear film breakup time most powerfully. That's the one that you really want to focus on the most. If you take a patient that's certainly in the dry eye range, you'll see the tear film breakup time relatively low. You'll see the average TFSQ number over 0.1, and the surface area of breakup may be much broader than, say, 2 to 4%. You can look at the graph down here and notice how the tear film surface quality is relatively consistent immediately after the blink. So at this point, here's the blink. Then the tear film moves towards stabilization, achieves stabilization, then it begins to slowly break down. And that's why you see the dots going higher and higher up on the chart. There's more surface area in breakup. If you look at the colorized topography, the dark blue is where the tear film is very smooth and even. Red is where you have breakup. Now, if we took a healthy 22-year-old patient and looked at their tear film, you see a very big difference. The graph shows you this flat line where the tear film is so stable for such a large period of time past the typical 12-second interval that we would call the point where breakup should occur. And we're seeing that after that 12 seconds, then the tear film begins to break up. So we have a tear film breakup time of 14.5 seconds. We have an average TFSQ score of well under that 0.1 threshold that we talked about, and a surface area in breakup of only 1%. So the best way to do these tests, according to Laura Downey's study in 2015, was to do 3 consecutive tear film surface quality tests on each eye and then average them out. The average tear film breakup time of the 3 should give you a really good idea of where that patient stands in terms of dryness. She found it has both a high sensitivity and specificity for measuring dry eye. Now, one of those things that can be challenging when you receive a corneal topographer is to determine which analysis do I use and when. Should I be using the tangential all the time? Should I be using the axial in periodic cases? When do I use any one of these numerous analysis options that corneal topography companies provide us? Well, let's go through some of them. And the axial is one that you may favor in that it provides an understanding of eye power. How does the anterior surface contribute to the patient's vision? For instance, we can see a beautiful spherical cornea here, maybe an ever so slightly mild astigmatism, but it's relatively a spherical cornea. Then we have our figure 8 or hourglass shape astigmatism, a width rule cornea, flat meridian horizontal, steep meridian vertical. We can see that this is a relatively apical astigmatism. Notice the green 360 degrees around, indicating we have a spherical peripheral cornea. Astigmatic center, spherical periphery. Here we've got our oblique astigmatism, and here are against the rule astigmatism. So axial helps us to understand the power of the eye. It helps us to understand when we're dealing with regular or irregular corneal astigmatism. For instance, here we have a very high corneal astigmat. We have a limbus to limbus astigmat, but the upper hemisphere is a mirror of the lower hemisphere. One side, the lateral, a mirror of the opposing side. So we can see that this eye is very symmetric between meridians. We would be able to correct this patient to a high level of acuity with spherocylinder refraction. By comparison, this patient doesn't have one hemisphere or a mirror of the other. Superior of the pupil is not a mirror of inferior of the pupil. This is our keratoconic patient, our irregular corneal astigmatism. Then in between, we can see this patient may not correct to the highest level of acuity. Would you expect this patient should achieve 6/6 or 20/20 vision? And because the eye is slightly asymmetric, that might suggest that we may need our GPs in this case to provide the best quality vision possible. Or if we fit soft lenses, we wouldn't expect that patient to get down to better than 6/6 vision, or even 6/6 in some cases. So axial is for power, tangential is for shape. When you want to understand the point of greatest curvature change, where's the radical change in the shape of the eye, you'd use a tangential. In this case, it helps us to appreciate in this pellucid marginal degeneration, where does the cornea have the greatest shift in shape. We can understand contact lens molding. Are our lenses changing the shape of the eye? And you see the point of landing of our small, rigid contact lens that's fit on this keratoconic patient. This beautiful symmetric blue ring is where that lens is aligning to the surface and creating a compression. So if we want to understand, are we creating any molding with our contact lenses, the tangential is the one. And along those lines of molding, in orthokeratology, the tangential tells us where our ortho-K lenses are positioning when the patient is sleeping. Now there's another map that we haven't discussed, but it has great value in contact lens practice, and that's the elevation map. What the elevation map does is tell us where the eye is high, where we may have lens bearing, and where the eye is low, where we'd have lens vault. So red is high elevation, blue is low elevation. Red is where you would have touch of a rigid lens. Blue is where you'd have vault of a rigid lens. So let's take an example. Here's a patient with a regular corneal astigmatism with the rule, limbus to limbus in shape, 4.5 diopters of central corneal astigmatism, or approximately 9.9 millimeters of corneal astigmatism. If we were to convert from axial to elevation, we understand from the red that our rigid contact lens should be bearing at 3 and 9 o'clock, and we should have lift at 12 and 6 o'clock, where you see the blue. So how do you come up with this elevation map? And imagine a spherical surface dropped on the topography and aligned to the center of the cornea. Then wherever the cornea is above that reference sphere, you see red. Wherever the tissue is below the reference sphere, you see blue. So this patient has a selected best fit sphere. In other words, the topographer chose 7.9 millimeters as the closest radii to match this eye shape. And where we see the red, the tissue is above the elevation sphere. Where we see blue, the eye is below the elevation sphere. So thinking of this, or looking at this another way, we might pull up the graph down below. And where you see the dotted line, that's the elevation sphere. So what it's telling us is across this white axis line, the tissue would be almost 100 microns above the elevation sphere on this side, and approximately 100 microns above the elevation sphere on this side. Now if we switch over to the steep meridian and we look at that elevation sphere at 0, the map is telling us that the cornea is well below the elevation sphere, about 75 microns down at this point. The tissue is approximately 75 microns lower than the elevation sphere at this point. Now another way we could approach this is to drop a contact lens on eye, to use the contact lens software and build a theoretical fluorescein pattern. So you notice your contact lens with your green dye underneath it, or theoretical fit. And what we might observe is the actual tear film across this line. So focus less on the contact lens and more on the graph down below. And what you're seeing is the edge lift here, the landing here, the apical clearance in the center, the landing on the opposing side at 3 o'clock, and your edge lift. So instead of looking at this, look at the profile of landing and lift on the graph. And that's how contact lenses are fit slightly different when you use your corneal topographer like the Medmont. So across this axis line, what we desire is a lens that clears the central cornea, lens that lands at 9 o'clock, lands at 3 o'clock with a healthy edge lift on both sides. This means the lens should be laterally stable. It shouldn't move with the blink, either nasal or temporal. It's sitting on the rails right here and here, as you can see in the graph here and here, and it's going to only be able to move, or should only move, in the vertical meridian with the natural forces that exist, lid force and gravity. So let's switch this around to the vertical meridian and let's observe the fluid along that steeper meridian. And what you see is a lens that's creating a massive amount of fluid at 12 and 6 o'clock. Just what the elevation map told us would happen, that this is a very toric eye, and putting a symmetric lens on this eye that changes so radically in elevation from this point to this point certainly suggests to us that we may need a back toric or bi-toric contact lens. Now, it's not just rigid contact lens fitting that the software can help us with. All lenses can be, we can benefit from the analysis the Medmont provides for virtually any contact lens, even soft lenses. As an example, one of the simple things you can do is measure the visible iris. Just run a quick ruler. It takes literally seconds to measure the visible iris. And would your approach to the 10 millimeter cornea be the same as your approach to the 13 millimeter cornea? Would you be using a 14 millimeter lens on a 13 millimeter visible iris? Would you be using a 14.5 on a 10 millimeter visible iris? Similarly for sclerals, how big a lens do we need on a 10 millimeter cornea? How small a lens can we get away with on a 13 millimeter cornea? So it's really important to measure visible iris. It'll help us to choose the right first lens more often. Now, to access the ruler, you would go to your menu and annotate and ruler. Then you're simply clicking and dragging the mouse across to the other side, white to white, clicking the cursor again, and it generates your measured visible iris. So that's using the ruler. You can also define the iris border by going to annotate and grab the iris. And what that does is allows you to pull this circle to the border of the iris. And not only does it define that point, but it makes this a constant on your attributes window at the bottom. So whenever we pull up this topography, we can quickly and easily see that it's an 11.5 millimeter cornea. Now, as we said, VID is important because for every lens, we should be choosing the right diameter of lens for the diameter of eye. Now, thankfully, most patients will fall into the normal bell curve and they won't need significant changes in lens diameter. But when you have patients that fall toward the extremes of the bell curve in diameter, then that's when we should be altering our lens appropriately. And as an example, what we use at the university is the visible iris plus 2.5 millimeters to choose our initial soft lens diameter. Now, could K readings describe a path of contact lens for this patient? The keratometer has long been our standard of care for understanding eye shape. But the keratometry values are taken at only 3 millimeters, so we're missing an awful lot of information that the topographer is providing. So should we be using K readings by themselves. And how limited are K readings? As an example, in this case, we have a patient 44.25 by 45 roughly and a half, so 1 1/4 diopters of corneal astigmatism. We see that it's a relatively normal flat K, not all that steep. So the K readings would suggest this is a pretty normal eye, maybe just a little bit toward the steeper side. But clearly the topography is saying that K readings aren't giving you the whole picture. Another thing we could do is if we click our cursor in the darkest blue, we can read within the pupil. The reddest, we can read within the pupil. There's an 18 1/4 diopter distribution of power across this eye. This eye is a very toric, is a very asymmetric surface. So there's an incredible amount of power that this patient has to try to discern through to be able to have quality vision. And clearly spherocylinder refraction is not going to provide this patient with exceptional level of vision. So clearly a GP is the right call. Now, if we were to use K readings as the source for our lens construction, how valuable will that be to us? And if you consider that K readings are taken at around 3 millimeters away from center, or pardon me, across a 3 millimeter diameter, 1.5 millimeters away from center, we're missing all kinds of information on the steepest part of the cornea, the center of the cornea. We're missing an incredible amount of the peripheral cornea. Now, if we were fitting 3 millimeter contact lenses, 3 millimeter K reading might make sense, but we're not. We're fitting large diameter lenses today. So getting data from 3 mils may not be ideal for fitting today's modern lenses. Now, is that totally true on the normal eye? Maybe not, but certainly on the irregular eye, it makes sense to try to collect more information. Now, if you consider that our standard corneal GPs today are 10.5 millimeters, our ortho-Ks 10.5 to 11 millimeters, our custom soft lenses could be almost any diameter, and then especially for scleral lenses, they're 15 millimeters, 16, 17 millimeters. So does it make sense to use 3 millimeters of the center to construct our lens from? Probably not. Now, as we said earlier, one of those valuable tools is the contact lens software. So we can place the lens on the surface of the eye and determine, is that pattern look acceptable? Does this lens have any hope of being successful? So let's take a particularly challenging case. Here we've got a regular astigmatism with the rule astigmatism, a limbus to limbus sill, but what really makes this a challenge is the high corneal astigmatism, 4 diopters, or about 0.8 millimeters of corneal sill, associated with the limbus to limbus astigmatism. We have a relatively high refractive astigmatism as well. So is it a diseased eye? No. Is it really, really challenging? No, but it's not the most straightforward case. And this particular patient was somebody who struggled with soft lens optics. The lens would not stay on axis with such a high corneal astigmatism. So we thought GPs might be the way to go. Now, if we look at the elevation map, what is it telling us about this high toricity eye? Cornea is highly elevated here, highly depressed here. So we may need a toric lens for this patient. Let's drop a symmetric spherical lens on this eye, just for fun. And we've got a base curve radius of 8.10 millimeters, about 4175. It's symmetric, it's spherical, so that base curve radius goes all the way around the clock. Now, across the white line here, the horizontal meridian, we see a lens that clears the central cornea, a lens that lands down at 9 o'clock and lands down at 3 o'clock with a healthy edge lift on both sides. Things are looking pretty good so far. Now, here's where they get kind of iffy. If we go to the steep meridian, at the vertical, take our axis line to the steepest meridian of the cornea, where the tear film is the thickest, we notice at the optic zone junction, the pink circle, inner pink circle is your optic zone. We have 120 microns heading north, 135 heading south. So that gives the lens plenty of room across this steep meridian to rock back and forth with the blink, to move a lot with gravity. So this lens may not be centered, may not be comfortable, may be moving so much it's creating inconsistent vision. And sure enough, this lens had decent alignment across the horizontal. However, it's that vertical meridian that is the challenge. We need a radius much steeper than 810 along that vertical meridian. So let's reconstruct the lens as a bi-toric with an 810 base curve along the flat, which was a good fit, a good relationship, but let's use a steeper relationship or steeper base curve along the vertical. Now you notice with the bi-toric lens, we have that similar pattern along the horizontal meridian. Edge lift at 9 o'clock, landing at 9 o'clock. Apical clearance of about 20 microns, landing at 3 o'clock, and edge lift. Same as what we had in the symmetric. However, in the vertical meridian, with that much steeper 745 millimeter base curve running vertically in our bi-toric lens, we now have this beautiful 20 microns of fluid running all the way across the optic zone, from optic zone junction to optic zone junction. Instead of having 120 microns up here and over 100 down here, now we have this beautiful looking 20 microns running all the way across the surface. So this lens doesn't have a lot of gap for it to be flexing, warping, tilting back and forth. It should be much more stable on eye. And when we place the lens on eye, of course, we get a much better relationship with that bi-toric lens. So the beauty of the contact lens software is it helps us to choose the right first lens. So that first lens that goes on eye is more likely to be the ideal fit. We're less likely to require exchanges and much less likely to choose the wrong path for the patient. So although the topographer may not always give you exactly what you need, it will usually tell you what definitely not to do. But you can consider on the regular corneas that you could custom order right from the topography. On the irregular corneas, we usually have to over-refract anyway, so use the topographer to choose the right first diagnostic lens. Now, is this a patient that requires a scleral lens? Is that an irregular enough cornea that we can look at the topography and say, yeah, for sure, that patient requires some kind of large diameter or scleral lens? Let's pull up that elevation map again and figure out how high the differential is. In other words, let's put our cursor on the highest point, the reddest, 163 microns. Let's find the lowest point, minus 171. So there's a difference or a change in elevation of 334 microns. Now, so what? What does that mean that we have a 334 micron change in height? Well, a study done at Pacific University by Frank Zhang and our team at Pacific found that when the elevation differential is under 350 microns, that's where corneal GPs worked with great success. You can look at the red bars. That's where corneal GPs were successful for these patients. Green are where we needed to use a scleral lens. What you can see is that in 88% of the cases, when the elevation difference was under 350, a corneal GP could be successful. Now, by comparison, when the elevation difference is over 350, that's where corneal GPs were less successful, that we needed to go with scleral lenses far more often. That's the green. So use that differential to guide you on when I should be starting with corneal GP, when I should be starting with scleral. Now this particular patient had 334 microns of differential under the 350 threshold. So that would suggest that we should be able to fit this patient with a corneal GP. So let's use the contact lens software. Select a lens that gives us somewhere around 30 to 40 microns of apical clearance in the diseased eye, 20 to 25 in the normal eye. So what we want to see is that that lens has enough clearance at the center to be able to clear over the cone here. Now also we want that lens to land in the mid-periphery to create stability of fit, also to reduce the lateral movement. And we're seeing a lens that lands at approximately 230 and around 830. So this looks good. Now we're going to take the lens to the vertical meridian and observe what's happening across that steepest meridian of the eye. So here we see at 12 o'clock we have about 33 microns of clearance. Down here we've got about 181 microns. Now bubble was created at around 90 microns, so this is a fair amount of fluid down here. But the elevation map said that the patient was under 350. The asymmetry was not too high, so we got a shot at a corneal GP working. And sure enough, that lens looked quite acceptable on eye. In fact, it was a very successful fit. We had this beautiful alignment across more than 75% of the surface, and then that increased edge lift that we expect, or increased inferior portion of the lens. Thankfully we didn't get a bubble, and the lens didn't hit the lower lid and catch that extra edge lift just due to the lid makeup of the patient. So we were quite successful. But if that elevation differential is over 350, that's where you may want to consider moving towards scleral, because we're going to struggle with the greater elevation swings from one side of the eye to the other. So remember that 350 microns on your elevation map. Now, today, scleral lenses represent such an important and large part of our specialty contact lens practices. It's really become the lens of first choice for the irregular and post-surgical eyes. How can the Medmont help us with these patients? It's a corneal topographer, not a scleral topographer. So is it possible that a corneal topographer could assist with these larger diameter lenses? And to understand the sagittal height story, there are two important metrics that we need. Number one is, what is the sagittal depth of the cornea? And a single Medmont topography will get you approximately 10 millimeters or more. A composite topography would get you limbus to limbus diameter. So easily the Medmont should be able to give us the corneal sagittal depth. The second metric that we need is to understand the angle of the peripheral cornea and how it runs into the limbus and sclera. If we can estimate this angle of the peripheral cornea, we can estimate the anterior chamber depth for virtually any contact lens. So the Medmont has an estimated height attribute. Chord Attribute is determining the height of the anterior chamber. When you couple this analysis with the composite map, being able to measure the peripheral corneal shape right out to the limbus, now we can estimate the height of almost any contact lens, and certainly scleral lenses. So what you do is you punch in the diameter of measure of your scleral lens. For instance, the lens I use is a 16.5 diameter that lands at 15 millimeters, and its sagittal depth is calculated to 15 millimeters. Therefore, I would put in an chord of measure, or diameter of measure, of 15 millimeters. Then the software will automatically estimate the height of the anterior chamber. In this case, it believes it's approximately 3,700 microns. Then we do this very simple formula. We take our estimated height measured by the Medmont, then add in your apical clearance recommended by the manufacturer, and that tells you the sagittal height of initial lens that you should pull out of your diagnostic set. So it's a very mathematical way that we can choose the initial diagnostic lens. Another thing that you can do with the Medmont is you can actually drop a scleral lens on the topography using the contact lens software. So it's not just a Corneal GP fitting software, it's also a Scleral fitting software. There's a number of lenses in the Medmont contact lens software that allows you to place them on eye, to manipulate the sagittal depth, manipulate the various parameters of the lens to observe how it lifts and lands on the surface of the eye. Now, this is very important because it helps us to optimize our final custom order. It helps us to choose the initial trial lens as a starting point. So there's many valuable things that this contact lens module provides us. One of the things that you'll notice about scleral lenses is they never sit up high and proud on the conj. They always sink into that soft, boggy conjunctival tissue. And the Medmont engineers have allowed us to settle the scleral lenses into the tissue. So you can create your own settling of 50 microns, 150, 250, any amount, and observe as that lens sinks into the tissue, will it come into contact with the limbus? Will the lens create any bearing over the cone or over the host donor area in a transplant patient? So using the settling factor with each one of the scleral lenses is kind of a valuable little tool. Now, for orthokeratology, I think everybody would agree that a corneal topography is pretty much indispensable instrumentation for fitting these lenses. Now, obviously, the slit lamp tells us an incredible amount about the fluorescein pattern, about any post-wear adverse signs that exist in the eye, but how does it help you to choose the initial lens? How does it help you to choose any modifications that may be necessary afterwards? And that's the powerful thing about corneal topography. It helps us to determine where to start. It helps us to determine how to modify what we have. Now, the most valuable function that the topographer does with the post-treatment analysis is the subtractive map. So we'll spend a little bit of time on this. The subtractive map compares before ortho-K to after ortho-K and tells you what's changed. How is it different? So it can tell you the refractive change, the treatment zone position, the treatment zone size, the lens position. If there's something wrong, it aids us in determining what to do next. So let's pull up a subtraction map where we have pre-ortho-K topography, then we select post-ortho-K topography, and with the subtractive, also known as a difference or comparison map, we see how the eye has changed. Notice in the axial, you get this big blue treatment area, relatively well centered to the black pupil. So in other words, our treatment zone, our effect to this cornea refractively is well centered to the pupil. Similar to what we discussed in the very early stages of this talk, axial is the best way to understand vision or power. Tangential, the best way to understand shape. So for axial, we can learn two things. If we click our cursor on the visual axis right in the center, compare the power of the eye before ortho-K to the power of the eye after ortho-K, where your cursor is in the center, it'll tell you the power change, 3.34 diopters of myopic reduction. We can say that the treatment zone looks well centered, so this should provide good aberration-free vision for this patient. Now let's switch over to the tangential map. And in the tangential, we're looking for this red ring of significant curvature change in the eye surface, where the reservoir of fluid is in your ortho-K lens. And we can see that the red ring appears very well centered to the black pupil. So this patient appears to have a lens very well centered overnight. And the effect appears ideally suited. So this is what you call your bullseye subtractive map. This is what you want ideally in orthokeratology. This is your axial topography of what's called the central island. You notice the blue treatment area in relationship with the pupil, slightly low inside the pupil here, below the pupil down here. We see the island that's described, the steeper central cornea instead of a flatter central cornea. So this is your typical steep fitting lens. And where do steep RGPs typically position? Low. Flat RGPs typically position high. So the central island is your tight fit, riding slightly low and steepening the central cornea up instead of flattening it. When we switch over to the tangential map, we look at the red ring and how decentered inferior it is in relationship with the pupil. So here we have our central island from a lens too tight in the periphery and or too high in sagittal depth. So an easy adjustment for our RGP manufacturers to produce the optimal changes that we need to this lens. Now the next and maybe most common adverse outcome from Ortho-K would be the smiley face. And this is one we see with great frequency. In practice, you would normally see about 80% of your cases would come back in the first wear with bullseyes. The balance of the 20 are usually smiley face outcomes. Very small amount might be central island, but most of them are smiley face. And that's where you see a blue treatment zone positioned high in relationship with the pupil. And then you have your paracentral steepening that we always have, but it may be decentered or displaced superior and more than we want it to. So we're getting myopic reduction here, we're getting myopic increase inside the pupil down here. So the axial map is saying we had a 2.3 diopter myopic reduction, which is why smiley face patients are normally quite happy with their vision in the AM, but the decentered treatment zone and sometimes paracentral steepening inside the pupil creates reduced quality of vision. So a smiley face patient will often report their vision slides very quickly toward the afternoon and into the evening. When we switch over to the tangential map, we see a red ring decentered high in relationship with the pupil. So again, RGP lenses that ride high are typically flat. RGPs that ride low are typically steep. We're seeing with the smiley face a high riding lens. So we need to tighten up the alignment zone of the lens to bring it down. Now your frowny face is your last outcome, and it's actually not that bad. It's more like a good bullseye, but slightly tight, and it rides slightly low. So we see the beautiful blue treatment zone. We see the RX change in the center, 2 3/4 diopters. The bad news, of course, that we have some steepening inside the pupil. Often frowny face patients don't complain about their quality of vision, but if they do, you know exactly what you need to fix here, that we should loosen up the alignment zone, allow the lens to come up. Again, a frowny face is like a steep fit. Steep fitting lenses typically ride low, so we'll loosen it up just a hair. Tangential map shows us a red ring decentered low in relationship with the pupil. Notice the red ring is 1 millimeter inside the pupil here. It's slightly below the pupil here. So the red rings are describing those various zones of the Ortho-K lens and how it's molding the cornea. So these subtractive maps become your best friends in Ortho-K analysis. And the Medmont, as you can tell, gives you such beautiful appreciation of what we have. Is it the ideal bullseye? Is it that high riding smiley face outcome? Is it central steepening? Is it a central island? Is it a good bullseye that's riding a little bit on the low side? Is it a frowny face? So the Medmont Topographer is one of those tools that really helps us in specialty contact lens practice. With the composite map, that allows us to image 100% of the visible iris. Then we can convert that to an elevation display and drop our specialty corneal GPs on eye. We can drop our scleral lenses on eye. The reflection-based topographer that the Medmont employs allows us to reflect off the tear film, so we can have an understanding of tear film breakup time, of the relative degree of dry eye that this patient is facing. And then in analysis such as orthokeratology, we have these beautiful displays with the Medmont that really help us to appreciate what's going on.